Good afternoon, everyone. I'm Shireen Tarwulsi McCarthy. I'm the director of NatSen International. It's a new social research program at the National Center for Social Research. At NatSen International, we engage with a broad set of social policy issues, global social policy issues, actively bridging global thinking with local expertise. And our goal is to use social research to empower societies around the world to shape policy and practice. Now, global health policy is one of six core work streams that we specialize in, that we focus on. Others include a focus on violence and counterterrorism, gender and social inclusivity, and governance and economic growth. I'm really delighted to welcome you all today to this discussion, a collaboration between the Global Health Center at the Graduate Institute in Geneva and NatSen International. We will be looking at COVID-19 and reframing the discourse on global health equity, addressing challenges, trade-offs, and opportunities. Now, allow me to start off with contextualizing our discussion today. As many of you feel, it's very difficult to focus on anything other than the situation that's unfolding in Ukraine, and all the images of destruction and displacement. They've been very upsetting. I mean, for me as a mother, I feel for all the women in Ukraine that are fearing for the safety of their loved ones. Ukrainian refugees share the same bitterness of others like Afghan, Sudanese, Yemeni, Nigerian, and multiple other nationalities, and all of us who have experienced or worked or researched conflict-affected contexts. Still, we have seen how race and geopolitics continue to play a role in the swiftness of solidarity and how the response, how quick the response has been. So while the war is indeed recent, a lot of the issues that are at the heart of this conflict are very much related to questions on equity and solidarity that are very, very old. Now, to the subject of the discussion today and to the questions related to health equity, grappling with the challenges of global health equity are not new. Again, a lot of the issues that we're dealing with are very old and very, very common, and the international system has been grappling with them for a very long time. Some of us will actually remember the Rio Declaration in 2011 on the social determinants of health, which actually called for health inequity to be put at the forefront of political agendas around the world. Now, the Rio Declaration recommended the adoption of health in all policies as the best and most effective strategy to tackle these inequities and their structural determinants. COVID-19 has and continues to be quite a sobering moment in our understanding of the extent to which there has been quite limited progress on global health equity. Through the course of the COVID-19 pandemic, we have seen international cooperation both succeeding but also failing. We've seen the discrepancy between the pandemic response in Western countries and in non-Western countries. We've seen the gap as being very stark. Suffice to say that the UK has now dropped all COVID-related restrictions, while a country like DRC has only vaccinated less than 1% of its population. It is important for us today to start thinking about the lessons we've learned from the last 2 years. It's also important to reflect on the wealth of evidence and knowledge that we have to help demonstrate what approaches work to health equity and what don't. Perhaps this is also an opportunity for us to reassess and rethink and reframe global health equity in a new light. So today, and with everybody that's joining us as members of the panel and with all of you joining us online, the discussion is focused on three core questions. The first question is, what has changed, if anything, in the discourse on global health equity since the outbreak of the pandemic? The second question is, what have we learned about the opportunities, the trade-offs, and the challenges of ensuring equitable access to healthcare? And finally, what does the future of health equity look like in a post-COVID world? Now, joining me in this discussion today are very distinguished speakers. Our first speaker is Luisa Anria, who's a social scientist who applies political anthropology to studying community experiences of epidemic preparedness and response and humanitarian emergency interventions. Louisa's work integrates social science perspectives in biomedical interventions and scientific research. She's worked extensively on the Ebola response in Sierra Leone. Welcome, Louisa. Joining us as well is Tamem Lauded, who is the managing director of the Global Health Center in Geneva. And prior to that, Tamem had worked for MSF. Tamem is a Syrian medical doctor and humanitarian worker with 20 years of experience in humanitarian medicine, forced displacement, non-communicable diseases, access to medicines, and epidemic outbreaks. Tamem has first-hand experience and knowledge of what it's like to be in a humanitarian crisis and trying to ensure access to healthcare for everyone. Also joining us is my colleague, Dr. Priya Gambaita, who's the Director of Health Policy at the National Center for Social Research. Priya is an expert on health governance, transnational care, and the social determinants of health. I'm really very honored to be joined by three very distinguished speakers with very different types of expertise and a very multidisciplinary outlook and understanding of the questions and the issues related to health equity globally. Now, as you may have guessed, this session is going to be run as a conversation. So it's not going to be a set of rehearsed presentations that each one of them is going to give. It will be run as a conversation followed by a Q&A session. So please, if you do have questions, please do type them in the Q&A box. And I will post them to the panelists following the conversation that we will hold with them. So, for the first part of this discussion, as I said, I want us to reflect on what has changed in the discourse on global health equity. Now, let me underscore and highlight why this is important for us. While the discourse on health equity is currently very much focused on vaccine equity in particular, we know that the realities in low and middle income countries are much more complex. There are contextual, political and systemic problems that make addressing health inequities quite difficult in those countries. And here I remember a paper that was written by Huda Rashad from the American University in Cairo and others who have pointed out that in developing countries, the conversation on equity is actually quite different. The incentives are very different from those in the Western world or in developed countries. In the West, health equity is mainly a policy discussion. It is primarily about policy and practice. Whereas in low and middle income countries, we see governments continuing to view health inequities as mainly inequalities. And those inequalities are more often than not perceived as inevitable, or at least expected. So if you look at contexts like Egypt, or Yemen, Nigeria, or Sudan, in those contexts, each one of them is, of course, very different from the other. But in all of these contexts, health inequities are in the first interest treated as inequalities that are very much part of the country itself. And so their strategies for alleviating such inequalities tend to be monopolized and dominated by one sector, which is the health sector, rather than a cross-sectoral approach, a whole of government approach. And they tend to also be embedded with a very simplistic frame that is about behavioral change. That if people were to change their behavior, then those problems would be addressed, rather than addressing the more structural, contextual, broader policy and practice problems. So the question that I'm posing to the panelists today is about, has the discourse on global health equity really changed at international and local levels since COVID-19, recognizing the differences that I've just explained and I've just contextualized? So my first question is really to Louisa. You've done extensive research on epidemic preparedness in humanitarian contexts. In the countries that you've worked on, have you noted the shifts in understanding health equity? Are you able to reflect on shifts within the international space, both UN system, international NGOs, and so on, and on the national level, again, in the countries that you've focused on and worked the most on? Over to you, Louisa.
Yeah, thanks so much, Shireen, and everyone. And it's great to be part of this discussion. I'm really looking forward to it. I think it's a great question. And I'm not sure whether I would say it's a shift per se, because, well, firstly, because I think that I'd like to believe that international actors sort of knew already, but I think were less explicit in their analysis before. And secondly, because I think there's still a lot to be seen in terms of how much kind of COVID ends up reshaping kind of policy and practice. But I think in the sort of things that I'm seeing, discussions that I've seen, and I'd love to hear the other panelists' view on this, is that it's become increasingly very difficult to kind of pretend that politics isn't central to how we think about health equity, and that structural issues can be somehow separated, or that can be somehow kind of put aside with a focus on behavior change. So I think even if this was always the case and was always important, I think it's become much more difficult to pretend that this wasn't the case. And I think in the past, there's been, certainly in the global health sector, or even more broadly in the kind of development sector, there's been kind of an emphasis or an effort to kind of render global health issues as technical, let's say, and so to separate the technical and the political. And I think that COVID has made it very, very difficult to do that in kind of different ways. On the one hand, in terms of how evident it's become that kind of political decisions, national interests, sort of shape how people experience pandemics across different countries. And also within particular countries, kind of how social, political, and economic marginalization sort of influences how people experience the pandemic within their own countries as well. And that also means that we've seen kind of humanitarian and international actors having to call out, I think, much more explicitly kind of political decision-making by nation states. And I think the vaccine justice debate has been kind of emblematic of this, but it's not limited to that. It's kind of in terms of sort of seeing various actors kind of calling out vaccine hoarding and so on. And I think that's kind of just an example of that. Where we've seen a shift sort of from the sort of technical discussions of vaccine manufacturing, for example, to kind of making very evident how political histories and kind of current geopolitics kind of shapes that. And maybe kind of also within some, let's say, donor countries, sort of seeing how inequality and injustice, kind of racialized violence, for example, in the UK and the US has kind of structured the differential experience of the pandemic, has similarly kind of pushed I think the debate a little bit further, and kind of really making it very tangible what we mean when we say kind of structural, social, and political determinants of health. So I think that at the national level, that's what I'm interested to see. But I'm also, I think cautious about sort of whether that will, in the long term, actually lead into kind of policy and programming shifts. And I think it'll be interesting to observe that. And then briefly, kind of at national level, I mean, I work primarily in Sierra Leone, as you've said. I'm Italian, and I did some research in Italy as well at the beginning of the COVID pandemic. And we've seen, and I think there what was interesting was that the pandemic, again, sort of made very visible kind of how social inequalities were exacerbating different groups' experience of the pandemic. And we've seen kind of political mobilizing amongst factory workers in the north of Italy, for example, very much around that. So I think kind of political mobilizing has been interesting in that sense. But in Sierra Leone, where I work, I think it's kind of a unique vantage point to some extent because of the Ebola experience in West Africa. But I think there are maybe two things that might be relevant in terms of shifts in discourse that might be relevant for other countries as well. First, it was that sort of national and local and sort of district level actors sort of realized pretty early on that they were going to have a mount-to-mount response pretty much on their own to a large extent, and certainly without international expertise. And I think that's been quite a powerful thing in terms of kind of where we go next in terms of debates on localization and decolonizing. And then secondly, because Sierra Leone, I guess this is a little bit unlike other countries, but Sierra Leone wasn't hit as badly by COVID, or at least on the surface, not hit as badly as other countries. There was a lot of discussions, certainly at local level or the districts where I've worked, about the tensions between a perception of kind of global priorities and kind of global actors and northern actors specifically kind of determining what matters versus their daily experience of kind of advocating for everyday access to quality healthcare. And I think that tension became so stark during COVID in terms of, sort of saying, you're telling me, you're coming here to talk to me about COVID vaccines. That's important, but also I want to be able to give birth without risking my life. So I think those are the kind of maybe beginnings of shifts in discourse that I've been observing.
Thanks, Louisa. And I think the research that I've done also in other Middle Eastern countries kind of shares a similar reaction to yours, that the emphasis on COVID-19, the way it was also emphasized was very much kind of through a Western lens rather than a local Middle Eastern one. And again, I remember Yemeni respondents and researchers mentioning that Yemenis are going to die from lack of food or from the conflict rather than from COVID-19, and that there's a need for a much more holistic approach and much more pragmatic approach to what is happening on the ground in those countries. So that completely resonates. And I think what you mentioned also in terms of the shift in localization and the whole debate around localization has been noted by a number of NGOs, especially international and regional NGOs working in Africa and the Middle East as well, that they had to rely on local expertise. It was no longer a luxury or an option for them to be able to put people on planes or inject expertise in those countries. They really had to rely on local actors and local leadership. And that has caused somewhat of a shift. Whether or not this is going to be sustainable in the long term, I think is a question to be asked. Whether or not this is going to manifest itself in terms of donor engagement, I think that is also another area that maybe we can explore a bit further in our conversation today. But the other point that also relates to my question to Tamim, which you said very eloquently, that it is difficult, it's become difficult to pretend that politics isn't really central to all of this. And Tamim, you talk a lot about the need of understanding the nexus or the intersection between health and politics. Could you please reflect on that? What is your take on what has changed, if anything, in our understanding of the need for global health equity? And to what extent is there an awareness of the politics, as Louisa mentioned, and the economics of global health equity? Has that changed? Are people a lot more aware?
Thank you very much, Shireen and Louisa. I think let's take a starting point. In the first days of the pandemic, there was this the discourse on the great equalizer. The pandemic is the great equalizer. So here's the first fallacy, is the great equalizer fallacy. And it crumbled fast. I'm surprised that those big names, from President Macron to others who talked about the great equalizer didn't have advisors to tell them it's not going to be a great equalizer. It doesn't take, a historical or technical genius to figure that out. But they didn't. It was a tempting soundbite, and they used it quite aggressively until it stopped being usable. That collapsed fast. And then we started having the supplementary discourses. And what I'm trying to say here is that there hasn't been a pretense of a need for health equity or a desire for health equity at any point in this pandemic. We were talking extensively about ventilators for months, and ventilators deal with a fraction of the cases, the most severe cases that actually need ventilators. So they aren't important for most patients at that time, and they are certainly not important for patients in countries or settings where you do not anyway have a basic infrastructure. You don't have basic passive oxygen to support people who are in severe disease. So it's not only the exclusively rich setting, we need more ventilators. It does New York, between the two gentlemen, the governor of New York and the president at the time, is 18,000 ventilators for New York too much or not, or too little? And then the complementary to that is, but South Sudan has only 2 ventilators. But who cares about ventilators? The whole prospect comes from a health context in the West where people don't die. So you have a situation where people stop dying at least of diseases that would kill them early. Hence, the ventilator takes a symbolic value of the one thing that will return things to their normalcy, which is people don't die. That doesn't apply to most places that are low resource settings. to places of poverty and so on. So the pretense of equity, once the lives in richer countries in the West started being threatened, disappeared. There's no equity to start with. And because that need to pretend that we are benevolent and equitable disappeared, when it was obvious that we need to hoard resources, the whole need to act on it disappeared. So it became even worse because we don't need to pretend. In Ebola, we needed to pretend to be compassionate. As a Western rich society, we needed to pretend to be compassionate. We needed to, when we were trying to prevent Ebola from coming to the West or becoming a problem we can't control, so we send aid to contain it where it comes from. This is the whole idea of global health security. Here, it stopped being necessary quite early. Hence, all the outrageous moves towards the vaccine apartheid, which is only one of the money inequalities, the sacralization of the conversation about COVID at the expense, as was mentioned, of every other disease that continued to happen and happened even more aggressively in the absence of any aid or resources when patients and so on, when healthcare workers were dying in low resource settings. So, I mean, there has been an astonishingly rapid exit from the conversation about equity. But let's go a step further, a step back, because we talked about the social determinants of health. The signs are in the writing. Social determinants of health talk about economic stability, about physical environment, education, food, yada, 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 health services, and they never talk about the underlying causes of poverty and inequality in economic income, in education, and so on. God forbid that we talk about, toxic nationalism or about neoliberal politics or about economics of lending and abuse that are directly responsible for those social determinants of health. So I will recall here the wisdom of Sarah Ahmad, who worked in a book called On Being Included, on diversity and inclusion discourse. And what she's found from studying universities in the UK and in Australia is that actually having a diversity and inclusion officer in an institute is a bad indicator. Because if it was such a concern, why would you need to hire someone who has no authority so they can spend their days trying to convince you as a leadership, who supposedly is convinced anyway, to do something that you should have done in the beginning? If we were convinced that there's health equity, and here she says, equity regimes are used to enforce inequity regimes. And this can be seen to have happened in health as well. Because we keep talking about equity when the starting point of a health equity is an equal opportunity to life, to health, to a basic set of health services. We haven't established that or desired that in almost any context I know of. We have come to accept that in South Sudan, maternal mortality will be high. We might reduce it a little bit, but we have no ambition of reaching a zero maternal mortality as we have in most Western countries. So health equity is a phantom we claim when we want to talk about our charity and the pandemic has changed that discourse. The depoliticized discussion about health, where we talk about the symptoms but not the causes, in the sense it stripped them bare. The king has no clothes, and the health equity king has no clothes in this case, and it will be very difficult to reclothe that king. So from being the depoliticized stance being taken away from, inaction is action. Depoliticization is a political position. We have no luxury of doing that. The rich have gotten richer, the healthy healthier, the poor poorer, and the unhealthy more sick. And we have an option of doing the don't hear, don't see, don't talk, or we have an option of saying health is a fundamentally political act. providing health is a fundamentally political act. And what remains is choosing what politics, as healthcare providers, as people who are concerned with the health of others across borders, with people who have adhered to the institutionalized health equity discourse for decades, where do our politics stand today if we are to be honest to what we have claimed over the past period? There is a status quo that has absolutely succeeded in some cases. We have an extended program of immunization that has saved millions. We have introduced oral rehydration solutions and zinc and stopped massive mortality from diarrhea, and on and on and on. But they aren't equity regimes. Those aren't trying to achieve equity. Those are trying to reduce mortality. Those are trying to reduce discontent as well. And in a way, if I was to pretend to be a Marxist for a moment, I would say that just like capitalists reducing working hours so they wouldn't have a rebellion or wouldn't have too many sick workers, a provision of rudimentary healthcare and denying the causes of ill health might be an aesthetic rather than a treatment. And if that's the case, then those of us who work on health need to start, polishing up our politics and seeing where do we stand in this. Are we being instrumentalized towards a politics we don't agree with, or do we agree with it? Or are we being taken for a ride? And this is where the question of politics becomes significant, because it requires a conversation between us and our patients and the communities that are at higher risk of ill health.
Thanks, Tamim. I think you've made a lot of important points here, that when we're talking about the intersection between politics and health, you're really looking at multi-levels. So there's a question around the political economy of the discourse itself, what we mean by health equity, because it is a moving target, isn't it? Because for some people, as you said, it is about the reduction of mortality rates rather than raising the level of ambition to the provision of high quality healthcare, which is what universal healthcare should be about or is about. And so it kind of, the discourse on health equity gets lost in implementation. It becomes something completely different from what its original purpose or what its original intention should and could be about. The other thing that you've also mentioned is that there are so many spaces of inequalities that are there that need to be addressed as we're looking at health equity. And again, it takes us back to the Rio Declaration that I mentioned at the beginning, which was about in the inclusivity or the inclusion of health across all policy areas. So you look at health when you're looking at economic growth and agricultural growth. You look at health when you're looking at gender equality. It becomes a common agenda that is owned across various policy areas. And then the last point that you've also, very much raised in your remarks is about how do we get to a point whereby we can avoid that tokenistic engagement in health equity for a period of time, and then the whole discussion just frizzles out into nothing and things go back to business as usual. And here is a good segue to my question to Priya. Now, NatSen has recently published research on the UK that pointed out that social attitudes have actually not changed as a result of COVID-19. Now, within the policy space, has anything changed in approaches to health equity? Do you think that there has been a shift, there has been a learning or that reflection point on the UK's experience responding to the pandemic, where there are issues related to equity locally with regards to minority groups and so on? Has the conversation changed within the health sector in this country? Over to you, Priya.
Thanks, Shireen. Thanks, Louisa, and thanks, Tamim. Great to be here this afternoon talking about this. So, as you mentioned, Shireen, the research you're talking about is the British Social Attitude Survey. Okay, so it's one of our flagship surveys that we conduct at NatSen on an annual basis. And overall, yes, you're right that the public's views on welfare, public spending, and individual freedoms have changed very little since the pandemic began. But there is some nuance to that. So there is some sign that slightly more people now regard Britain as an unequal society. And that's more evident among younger people who've been particularly impacted in terms of the pandemic with regards to their mental health and to employment prospects, right? So that's just one thing I'd like to mention sort of in relation to the research that you're citing there and what we can take from it. In terms of the conversation on approaches to health equity within the health sector, and I might go slightly broader than just the health sector, if that's okay, but I will talk about the health sector. What the type of work we do at NatSin is often, we do a lot of evaluations of services and interventions, but we're not just doing impact evaluations, which are very, very important in terms of like the health economics aspect of it as well. But we're looking at process evaluation. So we're looking at how can these new interventions and new innovations be embedded. And so we understand the mechanics of different health teams, different practitioner groups, the disconnect between patient needs and practitioner approaches and that kind of thing. So that's just where I'm coming from in terms of my perspective. But first of all, there's been an emphasis on funding. Now, this is an obvious point, but an important point, and a point that needs to continue to be made. So the conversation within the health sector is that I think it's shown that we need to remember funding that underpins the service delivery and what we are able to provide. In terms of, the UK prides itself on being able to, we're talking about health equity and access to health as a human right. And that the care is available at the point, available for free at the point of delivery and at the point of access. So there's been an emphasis on funding and ensuring that essential services reach the most vulnerable people to meet their specific needs, regardless of what wider crisis we are dealing with, right? Secondly, there's been a call for testing and trialing innovations, which bring together healthcare providers, but also partners that are not obvious partners to healthcare providers, okay? So I'm talking about community-led, community-based organizations, which were really integral to supporting the vaccine effort, particularly amongst first-generation members of the British, of the Black and minority ethnic communities within the UK. So it's brought together these healthcare providers and partners that would not have otherwise worked together as intensively or at all had it not been for the pandemic. And we've learned from that, and it's resulted in facilitating learning and benefit to groups and particular local areas, and that we should build on that. And then from those within the health sector, we have been made aware that they need more hands-on support to address poorly performing care pathways. We've done a lot of work in our team on cancer pathways, early detection, a faster diagnosis of various types of cancer. And there's what keeps coming, and we were doing this research before and during the pandemic. And there is a need for more hands-on support to address poorly performing care pathways, because those care pathways are nearly always located in areas that are deprived, that are ethnically diverse, and their support is needed for those poorly performing care pathways to improve those pathways and upskill local teams that are meeting the needs of those communities. So I think it's less about the conversation changing than it is about emphasis on some of what we already knew and warnings that were already given for a long time around the relationship between economic circumstances and health status, but also generations of certain subgroups and certain communities having poor outcomes with little effective intervention. But I'd just like to make one final point as well, is beyond that, what has been positive, and it's kind of links to what Louisa was saying around, it's not just about being able to get your vaccine, it's about being able to deliver your baby safely. It's about this, about more holistic approach, is that there has been none of the government departments or none of the key decision makers or policy makers have been able to ignore health. And increasingly, when I see invitations to tender and research funding opportunities, health is becoming more embedded into approaches to understand more other societal challenges. And so the importance and centrality of health to all our opportunities, educational, employment, social participation, is becoming more emphasized, and it's becoming more prominent. Thanks, Shireen.
Thank you, Priya. I think that there are a number of very important points about the UK context in particular, and what has or has not changed in terms of the experience with the pandemic. And I think what you've noted in terms of that shift, slight shift towards realizing or understanding Britain as an unequal society, or just exacerbating that sense that Britain is an unequal society, can actually have like an acupuncture effect into a number of other areas, and including migration, including level of inclusivity to various minority groups, and so on. And so it'll be interesting to see through the British Attitude Survey if those changes later on actually take place, and kind of draw a link between them. But what you also mentioned about community-based organizations and really having to have a much more localized approach to the pandemic, which Louisa would agree with me was very much the experience with Ebola in terms of the Ebola response, is that it wasn't really addressed or understood until there was a realization on the part of international NGOs and organizations. They needed a much more localized response, much stronger collaborations, and really the capacity to sit and listen, understand how local leadership, cultural and traditional practices can help and be part of the response. And then finally, what you mentioned is a holistic approach is something that we are now very much hearing from the WHO and from a number of other international organizations about the need to address multiple facets or multiple dimensions in order to make or take a step forward on health equity. So now this moves us quickly into the second part of the discussion today, which is about addressing what are the challenges, the trade-offs, and the opportunities for global health equity. Now, for NatSen International, and in collaboration with a number of other teams, we are building a research agenda around global health equity. And through the literature, and through engaging with various actors and stakeholders within that space, government, civil society organizations, people who are part of the medical sector themselves, I was actually struck by three main issues, or three main areas that would warrant close examination. The first one is the data gap and the need for robust health surveillance capacities in countries where data on health remains limited. And sometimes you do have data, but it hasn't been processed, or you've got data, but there's very limited access to the data that's available, or there's complete absence of surveillance. And so that infrastructure of information is very much needed in order to understand where the gaps are, where the needs are in developing a health equity intervention, health equity agenda. The second area which has emerged so far in our discussion is quite central, is really the political economy of equity. And ultimately, this is not just a conversation of health systems. It's not just a conversation about, the hospitals and the instruments that you have. It is a question about politics and economics. It's about the political and economic context and the intersection between the structural and policy dimensions of health equity with the context within which the whole conversation is taking place. And thirdly, I think there's also a very stark disconnect between evidence, policy, and practice. Even when the evidence is there, uptake remains quite limited. And so, for example, one of the countries that seems to have an expanding body of evidence on health equity is Tunisia. But in terms of policy implementation, they're still very much lagging behind in terms of being able to translate that evidence into policy and practice. So let me start off with Louisa again. With regards to the data gap, in your research, you do adopt an interdisciplinary approach, integrating anthropological approaches to the study of global health. What are the methods of, the merits of your approach, in your opinion? How does having a multidisciplinary approach help address some of the data gaps that I've just talked about? And how can it bring value, knowing that data scarcity remains a problem in a number of countries around the world?
Yeah, thanks. Really, really important discussion. I mean, I guess the first thing to say is to link it up with to what Tamam was saying just now. So for me, I think that the way in which we choose what we decide to know and how we decide to know it is linked up to the kind of political questions that we were discussing just now, right? And very much linked up to what kind of imagination of global equity is possible and which aren't. And so I guess I'd say that, I mean, at the moment, global health and certainly the epidemic preparedness and response space is still kind of very much dominated by biomedical and quantitative approaches. And I think an interdisciplinary approach, especially kind of integrating social science insights, is really important because, as we were saying just now, kind of health generally and certainly kind of the experience of pandemics is kind of has social dynamics and socio-political consequences as well as drivers, right? So it's extremely important to be able to understand that and to piece together these kind of more, this much more complex and more nuanced picture in the ways in which we understand what's going on in practice. And as you were saying, I think it's true that the Ebola outbreak is often used as an example of a space where this interdisciplinary approach, after several kind of problems, became more accepted, and it's often used as an example of where it was productive. And I think this was in sort of several ways. I mean, firstly, in terms of kind of using qualitative research to develop much more creative and contextually adequate responses to Ebola. So, you know, kind of over time, developing much more safe burial practices that could take into account kind of religious concerns and religious religious practices in the places where we're working. I worked and still work in the Ebola vaccine trials, for example. So they're kind of working with clinicians to integrate kind of participant experiences and concerns and into the design of the clinical trial was really important. But also in another way, and again, this links up to our discussion of politics, because you know, there are a lot of concerns and anxieties and even kind of hesitancy or resistance or refusals certainly during health emergencies. And bringing in an interdisciplinary approach allows us to move beyond this kind of behavior change or kind of blaming individuals for not understanding properly what crisis they're facing. Or, you know, kind of throwing more information at them because the problem is an information gap. And rather to kind of reframe this and use kind of social analysis and political analysis to understand how rumors, for example, are politically grounded or are a product of histories of extraction and exploitation and so on. So we're able to understand these dynamics in much more depth and to respond to them in much more effective ways. I'm not sure that we've learned many lessons from that for the COVID response, I'd have to say. And I think that there hasn't been enough kind of emphasis on interdisciplinary work. Certainly in the UK, there were very broad assumptions made about behavioral, about sort of social behavior that didn't pan out because it didn't take this kind of much more grounded interdisciplinary approach. So I think that it's important to have an interdisciplinary take anywhere, whether you have sort of data scarcity or not, because in a sense, we are always data scarce if the only data we're collecting is epidemiological, for example, or kind of quantitative data, right? And so I think, you know, there are important ways in which we could integrate these interdisciplinary approaches to bring in kind of social network analysis and how we think about modeling, for example, or these kind of, you know, analysis of rumors that I've just mentioned. You know, so I think that's important. But then if we think, as you're saying, of places where data is scarce for various reasons, often political economic reasons and kind of defunding of public health, certainly certainly in places where I've worked, like Sierra Leone, then interdisciplinary approaches are potentially even more important. So over the last few months, I've been working with the epidemiological surveillance team in the north of Sierra Leone. And their kind of our efforts to kind of integrate narratives into their epidemiological surveillance work has been really important because, for example, if you're not collecting or if it's difficult to collect mortality data, narratives about death in the community, for example, or particular illnesses in the community becomes really important. So bringing together all of these different perspectives helps you to triangulate, to have a much more nuanced and complex picture of what's going on on the ground. I think the last thing I'd say, though, and maybe this links up to what we want to discuss about kind of evidence and policy, is that at least in my experience, there is still a huge hurdles and a huge gap in terms of really accepting and integrating these more interdisciplinary approaches. There is a lot of kind of lip service paid to interdisciplinary approaches, but not much in practice. And in particular, in terms of what kind of evidence we think counts and we think is valid. And there, you know, for all the talk of kind of community engagement, community feedback mechanisms, and so on, in my experience, kind of community voices or qualitative research that tries to engage these narratives is still not seen as kind of valid evidence to a large extent, or certainly not seen as on par with other forms of evidence. And so I think there's still a long way to go in terms of really doing this work in an interdisciplinary way that kind of puts kind of people's experiences at the center of the debate.
Thanks, Louisa. And I share that frustration as well, that I think analysis on coping strategies, how communities are actually coping with pandemics, diseases, how they respond and so on is very much lacking. And again, the research that I've done, for example, in food insecurity in Yemen, there's very little that is out there about what people are actually experiencing at a much more localized level. What you usually get is just blanket data and analysis about food insecure contexts or regions in the country, without a much more granular look at really how it's affecting particular groups, especially vulnerable populations and marginalized groups and so on. And I think this is very much the case also within the health, the global health policy focus, that there is a need for a lot more research that is community-led to inform policymaking, rather than just a reliance on large quantities of data that may not be accurate or done to a high quality. But also, I mean, this also takes us back to that question of the political economy of global health equity in a number of countries in low and middle income contexts, and how that agenda can sometimes get monopolized or can sometimes be used by various warring parties, for example, in a humanitarian crisis. We've seen a number of examples, for example, where the pandemic has been actively weaponized in parts of Nigeria, in Libya, and so on. Tamim, what is your take on some of the contexts that you have worked on, the Syrian context being, you know, an example, and how do we get that political economy approach, in addition to that multidisciplinary approach that we've been talking about, how do we get it front and center and on the agenda in addressing the question of global health equity?
Thank you very much. And I do appreciate absolutely both the discussion on the multidisciplinary approach that is needed, because it is evident that, you know, a biomedical, you know, a description that is either biomedical or epidemiological is insufficient to describe what's happening. And how did it end up collapsing any pretense of equality or desire for equality? But I want to quote a 19th century physician who said, Rudolf Virchow, who said, an epidemic is a social phenomenon that has a few medical aspects, and this is where we start to fail in trying to understand things through numbers. And if I'm feeling like quoting, you know, Mark Twain quoted Disraeli saying, you know, there are three kinds of lies and damned lies and statistics. There has been a misuse and often abuse of the imperfect, often severely imperfect knowledge that we have of the pandemic that has translated as far as we could into numbers. The one thing, for example, is there has been the discourse of Africa doesn't have COVID, to the extent of disingenuousness to what should we learn from Africa about not having COVID? Suddenly everybody forgets about the things we know very well. People in outbreaks in many low resource settings die in community. Community death is extremely high. They don't reach health facilities to be counted as dead. There is no health facilities, registration systems, you name it. But viciously, and the argument was, oh, but this is this is the affected Europe. We really don't need to worry too much about vaccination in Africa, because anyway, the mortality is all in Europe. And people who are otherwise really smart and experienced and know that stuff suddenly became incapable of seeing beyond the numbers. We have reduced the whole thing into a map on Johns Hopkins University website that shows us who's dead and who's in circles of different colors, which is extremely valuable. But there isn't a better way to depersonalize the dead and the dying and people affected and strip the whole thing from its political and economic context. So what are we talking about? I think in a way we'd be misguided if we hadn't looked at this from an existing political economy, as you say, and a political economy view. Even if I simplify it due to my own lack of understanding, is who's selling, what's the commodity, and who's buying. And we try to pretend that sick people in poor countries are clients. It's just that they don't have enough money to buy in a competitive marketplace. And I fear that they aren't. They aren't clients. We have the market hasn't bent backwards to accommodate those clients, or despite their abundance, and even when they could pay, because this is not a perfect market. This is a market failure. But even though there has been not only a commodification of medicines, there has been a commodification of life. There has been a commodification of the people who are sick themselves, to use them as currency, so we can talk about our benevolence, our collective benevolence. We sold them to buy ourselves narratives. We commodified them so some countries can say, see, we're ignoring those because we only care about our citizens, elect us. There has been others that said, oh, we are putting nearly expired vaccine to give them to the poor people. We're benevolent, elect us. The commodification of life hasn't yet been talked about. And this is not new. It's just, as I mentioned in the beginning, the pretense of solidarity, when the rich have become a target themselves, stopped being a concern. So what was being done under a cover of benevolence and charity has become now just more honest. We have had repeatedly massive investments on medicines for the rarest of diseases, when we don't have any more antibiotics, basic antibiotics. Penicillin is in shortage. When we have severe mortality still from pneumonia in children and from sepsis. Penicillin is not produced because it's not profitable. So talk about political economy. It is inconceivable for us to talk about health equality in a privatized marketplace that is mobilized by market fanaticism, and where the policy is made. If you look at the studies on the health actors, global health actors, you'll find that almost all of them are located in two towns, in DC, New York on one hand, and Geneva on the other. If you look at the Global Health to a 50-50 study of 2021, you will find that 70% are of the CEOs and senior management in global health organizations are men from the global north, white men. 80% are from the global north, and 90% have studied in one of few universities in the global north. And that hasn't changed under COVID, and they talk explicitly about that. So having that, you don't need precise statistics to know that the poor die more than the healthy. As post-colonials scholars call it, in the Souths and the Souths in the North. You don't need statistics to know that those who have money are going to die, that those who are racialized are going to have less services, that women are less likely to get proper health care than men, that people with disabilities are not being cared for, and so on and so on. And sometimes this insistence on let's not do anything radical, crazy, like actually seeking equity, until we have all the facts. And since we mentioned Ukraine, you could see absolutely brilliantly, the world has reacted. And that's absolutely necessary. Guess what? They should have done the same for Yemen and Syria as well. And doesn't reduce the suffering in Ukraine, doesn't reduce the rightfulness of a reaction that is decisive, but exposes a problem of inequity. And that is similar. Providing healthcare to some, no one is saying don't provide healthcare for people who need it in the North. Absolutely not. But one has to question, when we have nearly 100% coverage of a booster of, a booster after booster in some countries, and less 1% coverage in others. And you look at the two maps, and I've used that metaphor before, and the maps of coverage of vaccine and maps of colonial empires almost overlap perfectly. You have to ask yourself, where do we stand, and how do we still believe the narrative? It's like in Arabic, we say, someone slapped you on the face 60 times, surprisingly. You could get surprised the first 1 or 2 or 5 times, but when the same narrative repeats itself forever, fool me 70 times, shame on me, actually. And this is where, again, we need to stand and say what is actually happening, not statistically, but politically and socially and economically. And using the disciplines like anthropology, whereby we go and learn from people rather than patronize them, and sociology, where we can see things, and then decide whether we still need statistics about mortality or so on to complement our, still lacking image about the injustice of health systems.
Thanks, Tamim. I was just going to ask you about the extent to which this discussion on global health equity is also a racialized one, or it tends to get racialized, that problems happen there, but they're not happening here because there are behavioral, regime-related, political-related issues over there, and what needs to happen. But still, I'm still posing that question to Tamim, but also to all the panelists. How do we get that political economy discussion to the foreground of the global health equity agenda, and how can there be a lot more transparency and sincerity and genuineness about addressing those issues? Because I think there is an agreement overall in the conversation now that the question of global health equity is a very multidimensional one. It's a historical one. It's not new. But there has been a struggle to really make a significant shift on that agenda. And there are various reasons for that. But one big reason is not realizing the level to which and the extent to which it really is about the political economy of the discourse itself, and local political economies that you also have to engage with. Now,
let me just say one little thing.
Go ahead.
I mean, we are a few steps ahead, and this needs to be mentioned because we are a few days after having lost Paul Farmer, who has been one of the figures who popularized a justice lens to look at global health. Whether you agree with everything he says or not is beside the point. The point is that we are now in a place where we can talk about health justice as part of a social justice. It's not entirely unfeasible. It's not common in policy circles, but it's not unfeasible. But we also are in a place where a hegemonic system of global health governance that, another one, rest in peace, is Gramsci, where the global health system is used as much to justify the hegemonic order that we have as much as it does provide policy to improve health equity. And this is important because, again, it goes back to what do we conceive? It's slightly easier for physicians because you have a patient, you close the door of the clinic, and your sole responsibility is the best outcome for a patient. Sometimes it's complicated, sometimes it's simple. In global health, we do not have that perspective. Who's our sole beneficiary? Is it the community? Is it the patient? Where is the best outcome? And this is where politics is required. This is where an ideological lens to look at the outcomes of health is demanded. And I don't want us all to have the same ideology. We're not going to have a Politburo for global health, but we need to acknowledge the necessity of politics and ideologies that are discussed openly at all levels, democratically, with communities at risk, and that lead to that, just like everything, context-specific, adapted, honest, adjustable, and uncorrupt, untainted approaches. It's not impossible. It's really not very complex. That's how politics happens in any democracy, and there's no reason for it to not happen in global health as a democracy.
Okay, thanks, Tamim. I mean, I think the discussion on those issues really continues, and the third half of the discussion today is going to be looking forward, what can be done differently. But before we segue into the third part, I'd like to ask Priya a question about that third key challenge that we have towards global health equity, which is the disconnect between evidence, policy, and practice. And using the UK context as an example, a country that has massive evidence base, you've got the ONS over here, you've got masses and masses of evidence that you can reach out to at the tip of your fingers. You've got an active policy making space, an active practice space. So to what extent have our health policies been evidence-driven? And what are the gaps in terms of evidence-based practice? And how does that impact the most vulnerable groups in society? Again, recognizing the specificity of the UK context, but there are lessons learned that can be extrapolated from this example. So over to you, Priya.
Thank you, Shireen. So I think the question is, to what extent are they evidence-based and to what extent are they data-based, right? So, I mean, data is important, okay? Data underpins research, and it has to, and we at NatSen, we house a number of very important national surveys around health. So whether it's about diet, nutrition, whether it's about general health or about sexual health even, this is important. It needs to be collected in a methodologically sound way, and it needs to be analyzed properly. Right, but there is evidence. I mean, that it's clear from my experience that there are very important gaps in terms of evidence-based policy, evidence-based practice, and I can talk you through some of those gaps now. But before I talk through specific gaps, I think sometimes the approach from policymakers, decision makers who put out these calls for funding and make research funding available is more about the state of the nation, what's going on. And as I said, that is important. Of course, it's an important part of the picture. But what about solution forming? What about going beyond data and going beyond figures to understand what is driving them and actually addressing them in a way that can actually make a difference to different types of health outcomes? So that's the first thing I'll say. And in terms of gaps in evidence that policymakers have access to, there are important gaps. And Louisa was talking about certain community groups and how research with these types of community groups is not always seen as being on par or a necessity, because yes, they do take time. It does take time to do these types. There are additional ethical considerations, even practical considerations around doing this type of research. But I'll tell you a quick story of when I was doing a project on satisfaction of social care services, and it was within South Asian communities across Hampshire, and it was Indian, Pakistani, Bangladeshi, Afghanistani, and across a range of religious groups, Hindu, Sikh, Muslim, and I spent a lot of time building trust with these communities and with the elders from these communities, because they didn't trust us, and they repeatedly talked to me about research burden. And when at the end of this project, I went back to disseminate the findings and close that loop and explain to them and thank them again for their participation, for allowing me into their safe space, into their community groups, into their meetings. I ended up volunteering in the end to be able to break that barrier, even though I was from the community. I think the idea was that if I'm from the community and I speak a community language, it'll all be very easy. When I went back and I talked to them and I explained to them the findings of the research, what we're hoping to do with it in terms of making recommendations for a social care practice, I got a standing ovation. And many of the elders came to me and talked to me afterwards and said, thank you so much for coming back. For it just shows that the importance of including these groups in the research process within our research community as important stakeholders and including them in what we hope to do with these findings for their benefit, not just from our own perspective, and continuing the conversation around that. So I just wanted to talk about that briefly. But in terms of some specific evidence gaps, I mean, we recently did a rapid evidence assessment on race, religion, and health inequalities, which is a huge topic area in itself. But we were trying to focus on some areas that are, that are still new in terms of fields of inquiries, like sexual health, for example, and maternal health, for example. So some of the things we found of is, there are gaps around everyday challenges for lower socioeconomic groups and minority groups in terms of, what are the everyday challenges they face? How do these challenges arise? A lot of them are underpinned by economic and employment issues and training opportunities. And then how do these challenges specifically contribute to stigma, to poor mental and physical health? This is a very important gap. It's like what Tamim was saying around what drives, what sits under the social determinants of health, beyond just categorizations of variables that we want to look at and domains of social life and public life. What is sitting underneath it? What is causing that from an everyday perspective by the people who are experiencing them? There's real gaps on repeated experience of discrimination over time. So what's the potential cause of poor mental or physical health in relation to repeated experiences of different types of discrimination that people face? We could do more in terms of coordinated policy responses as well. So I mentioned earlier how different I welcome the fact that different government departments and decision makers are understanding how central health is to different aspects of our life. But how coordinated will that response be over time in terms of addressing health and well-being challenges, and both within the UK and beyond the UK? So, for example, we know with HIV-related racial disparities, there are commonalities in what we can see in the UK, the US, and Canada. Could we do more in terms of joined up cross-country responses to develop, to target these types of inequalities and disparities? So, finally, the final sort of thing I want to talk about in terms of evidence and evidence gaps and evidence-based practice and that type of thing is that we need more longitudinal studies. We need to explore long-term impacts, but the long-term build-up. Why is this happening in the first place? When in the life course are specific health issues arising, and why are they happening at that time point? And what's driving the intergenerational links with patterns of health behaviors and disease? So Louisa was talking about behavior change, and it's not about blaming individuals. It's about understanding from an intergenerational perspective, what's happening around these health behaviors and disease, and where are they coming from, what's driving them. And similarly, as well as collecting data in the long term in terms of longitudinal studies, we need to do more in terms of long-term policies and long-term efforts to promote equitable life chances. Thanks, Shireen.
Thanks, Priya. I think you've made a lot of really important points about not just about the UK context, but what also can be done in order to mobilize globally towards action on the social determinants of health and increasing the evidence and information base. And related to that is the final question I'd like to pose to all of you, because I see that we're getting a lot of questions in the Q&A and the chat box. Now, last week, we saw the WHO announce that the first 6 countries that are going to receive the technology needed to produce mRNA vaccines on the African continent as part of the global mRNA technology transfer hub project. Now, these countries include Egypt, Tunisia, Nigeria, Kenya, Senegal, and South Africa. To what extent is that a solid, strong step forward towards realizing global health equity? What does that mean for future pandemics? Is this a turning point that we think it is, or is it not enough on its own? Other concerted efforts need to take place. So I'll start off with Louisa again, and then Priya, and then Tamim. Louisa, what is your take? What are your thoughts about sharing, technology and expertise on the broader global health equity debate?
Yeah, thanks. I just want to, because it's relevant, just take a quick step back to what we were saying about the political economy. And it kind of seems important to me to ask the question as to whether, we fix global health through global health, if that makes sense. So I think the question of, kind of political mobilization and kind of political analysis being really important is, I think, well taken. I think that's maybe kind of the ways in which we think about change and about how equity comes across may not be through kind of technical changes within the industry, but perhaps through kind of political mobilizing and kind of groups reframing their own ideas of equity and justice. So related to that, I guess, is this question of kind of technology transfer. And maybe we need to kind of take a bit of a step back. We've already mentioned it to some extent, but sort of why this matters. So understanding why this matters requires understanding what the problem has been, right? And I think that it's sort of clear what vaccine hoarding and kind of the holding of patents by pharmaceutical companies has done in terms of creating vaccine apartheid. And so a lot of groups, including myself and colleagues and many others across the world, had been calling for a long time for technology transfers and the dropping of patents. And I think that's really important on several levels, like certainly on the practical level of making sure that people have access to vaccines and that we address vaccine apartheid and vaccine distribution and so on. But it's also important on a political level in terms of political narrative and imagination, right? Because I think what's been really damaging and really dangerous has been that the way in which global vaccine distribution, even in the context of sort of hoarding and exclusion, has been around charity, right? And that narrative is hugely damaging and hugely dangerous. Firstly, because it's been ineffective, and that's point number one. But secondly, also because it kind of mischaracterizes Western nations as being sort of saviors or being kind of in solidarity when they're sort of sending over leftover vaccine vials. And not their role kind of certainly in kind of contributing to poor health outcomes across the world historically, but also very specifically in kind of contributing to creating or kind of single-handedly creating vaccine apartheid. So I think the charity model was hugely problematic. And so the kind of technology transfer approach is much more important. It's much more sustainable long-term. And it's extremely important that countries, certainly across the African continent, but beyond as well, are able to produce their own vaccines going forward. So with that in mind, I think that announcement is good. And I should preface this by saying I'm not an expert in vaccine manufacturing or IP law, and I think that would be important. But I think it's good in terms of equity, in terms of these discussions that we've been having. But my understanding is that this is good news in the medium to long term. So even with sort of South African scientists sort of being able to produce an mRNA vaccine, it will still take at least a couple of years, as far as I can understand, to go through the regulatory hurdles and go through clinical trials and so on. It would have been much faster, of course, if companies like Moderna and maybe also BioNTech and so on had dropped their patents, and that would have had a much more kind of immediate impact on vaccine manufacturing and production on the continent. So I think in the long term, I think this is probably going to be a good thing, but I think it doesn't necessarily kind of get certainly pharmaceutical companies off the hook, or kind of doesn't necessarily immediately have the impact on vaccine distribution that we think is important, that we would like to see, I think. And I think also kind of linking it up to that we've been discussing around the political economy of health, it also kind of really reinforces that, however long we've kind of some narratives within global health have made it possible to see kind of the interest of pharmaceutical companies as kind of in some ways alongside the interest of health equity. I think what we've seen with vaccine distribution has kind of taken that mask off, I think, to some extent, and made it much harder to argue that.
Thanks, Louisa. And I think what you've mentioned about the need also to change the conversation about health equity itself, to change its outcomes, rather than starting off with the outcome or the situation as it stands, but really that the paradigm of a charitable global north towards an underdeveloped and suffering global south is not helpful to any form of progress on global health equity. And unfortunately, again, and Tamim mentioned that with the Ukraine crisis that we're witnessing today, a lot of the journalistic coverage of it seems to fall exactly in that pattern. This is a civilized country, it's not a third world nation or an underdeveloped developing country, even though actually Ukraine is a developing country according to the Human Development Index. So there is that, the conversation itself, the perceptions and the incentives around the conversation needs to change for actual policy and practical shifts to take place. So, but again, I would love to hear from Tamim and Priya very quickly their thoughts on that WHO announcement and that shift towards sharing technology and expertise with a number of countries in the global south, if that takes us far enough and how we can capitalize on that. Tamim, over to you.
Thank you. I think it's absolutely good under the circumstances. And this is, here is us being conscientious of our position. I don't think sharing, a conditional sharing of technology after 2 years of the pandemic is really the revolution that everybody was expecting. But we're, in the end of the day, we're sitting behind our screens and theorizing. People, if you're hungry, you will take food when it's available, and no one can judge you for that. And emancipation hardly happens if people are starving. So it is a positive thing to start first dispelling all the myths about the incompetence of poor countries in manufacturing. Those myths have been dispelled by India and South Africa and Brazil a long time ago, but nevertheless. And to put an end to those arguments that have been used and abused by Western liberal democracies, that this, the sharing of technology isn't going to save the problem, hence stop the waiver on the TRIPS agreement for 2 years now. But the risk, what I fear, is that this becomes an excuse to not go further, to not say, this is a stopgap that we need now and that we will use now. But that's not a non-disclosure agreement or a non-litigation agreement. We still need to litigate the bigger case. We still need to litigate, how medicines are often developed by taxpayer money and then sold to those taxpayers. Again, how pharmaceutical companies supported by public money have made more profit than domestic product of many countries. How are we still accepting this sanctity of the market above, if this, we can argue about the size of this catastrophe, but it has repeatedly been called the catastrophe that once in a century, once in a generation, once in a so on. If that doesn't justify a revisiting of the market, then we have dug ourselves deep enough in a situation where nothing is more important than profit. And this is, just to say the last thing, pharmaceutical companies have had similar strategies before. So they have offered donations to not have to, so they're willing to give millions of dollars of donations to not have to talk about the IP, for example. And I'm not against taking the donations, but as long as we end up talking about IP nevertheless afterwards. So it is positive, and those countries will manufacture medicines, and hopefully that will be part of the decentralization of manufacturing capacities in the future, but it does need to be not the end in itself. This is not a victory. This is a skirmish that has been avoid a hill that we will not die on, and there is still the rest of that struggle to go on with, I think.
Thanks, Tamim. Priya, what are your thoughts on that question, the WHO announcement? And then we'll have to go to the questions from the participants.
Yeah, thanks, Shireen. I mean, I think Tamim and Louise will probably be able to talk a bit more about the specifics around the WHO announcement in relation to the vaccines and the technology sharing there. But I can maybe talk a bit more broadly in terms of what the UK could do differently in supporting, health equity in other countries within this post-COVID or ongoing COVID situation. So, I mean, we know that Global Health's main funders, set research priorities that respond only partially to the priorities of low and middle income countries and their citizens and their governments. So what the UK could do is they could help funders to expand their perspective and highlight where those research gaps are and that need to be addressed. They could work closely with those funders and apply pressure on them to reconsider and reevaluate their research priorities. Okay. And that would support the more full participation of these countries in shaping the global health agenda and in addressing it. And beyond that, we need further flex in the research infrastructure to better facilitate collaborative working between different in-country partners. So there was a little bit of that in the UK, which was very much welcomed, and across Europe, in terms of facilitating cross-country interdisciplinary research in terms of rapid response for data collection and analysis to address health challenges as they emerge. But that needs to go beyond UK and Europe. You need to remove bureaucratic and other barriers around collaborative working with different in-country partners to be able to work on conduct research on health equity. And we need to work more with them and understand how we can learn from each other. So as Tamim said, it's not about patronizing them, it's about working with them. And Louise also said something to similar effect, is that we need to work with them and understand how we can learn from each other in terms of evidence-based practice. An obvious way is examples of culturally relevant and appropriate care, best practices that we could understand and learn from in the UK, as well as sharing our resources and supporting capacity building. And these are things that have been discussed in research funding communications and where pots of funding have been advertised, but how much has been done in reality? I mean, there's always loads more we could do in terms of sharing resources and supporting capacity building. And I think it's done a little bit more in academia than in policy, but I think it's something that applies to the wider research community in its breadth. And I think one thing I welcome is therefore that this is something that NatSen as a major UK policy centre recognises, and it is obviously a key reason why we now have an emerging international programme of work. To have we want to make research work for society, but not just within the UK. Beyond that, so that's it.
Thanks, Priya. And I think, yeah, absolutely. And one of the work streams for NatSen International is on Global Britain. So Britain is a key donor to a number of the humanitarian crises around the world, to Yemen, to a number of other contexts. And not only that, it's got a pen holder capacity in a number of UN agencies. So it does have decision-making power to put that global health equity agenda to the forefront of a lot of the conversations that are taking place around peace building, around economic growth. And as we mentioned throughout the conversation today, health equity is very much cross-cutting a number of other issues and core agendas in southern countries and low middle income, but also conflict-affected contexts. So there's a lot to do there. But having said that, I think there are a lot of questions there, and I will highlight 3 questions that we've received so far, and we'll ask each one of our panelists to respond to one of them in the interest of time, because we've only got 10 minutes to go. One of the questions is about that children tend to be forgotten time and time again. And how can the new global discourse on health equity be inclusive of children, recognizing the fact that children are not voters, they don't have voting rights, they tend to be left out. And for that question, I would like to pose it to Louisa, perhaps. In the countries that you've worked on, humanitarian sector is now very focused on inclusivity and inclusivity of disabled people, of children, of marginalized groups. To what extent can that focus on children and vulnerable groups be at the forefront of a global health equity agenda?
Yeah, I think that's an interesting question. I mean, particularly in terms of, as you say, that children are kind of often, it links up to other things that we've been talking about in terms of how we conceptualize victims, right? And kind of how, and I think children kind of tend to be the kind of quintessential victims to some extent, and are kind of seen as not really as agents, I think, to a large extent, and they kind of appear in images of, humanitarian crises and so on. But I think there is a huge amount of certainly of research and more kind of creative research methods in the past couple of decades, I guess, that have been interested in kind of working with children as agents, as kind of members of society who have things to say and who experience health emergencies, for example, amongst other health issues. So I think it kind of, for me, kind of falls back in line with the discussions we were having about kind of expanding much more broadly the base, the knowledge base of how we understand health in a much more holistic way, how we understand the experience of health emergency by including, kind of a broader group of people and a much more diverse set of voices. So for me, it falls in. I mean, I think there are specific issues to do with children, certain ethical issues and so on. But I think for me, it falls into this discussion about, how do we diversify, how we define global health equity in the first place. And part of that is listening to a broader group of people.
Thanks, Louisa. The next question is to Tamim. Isn't the change in the focus of the discussion partly a change in who is leading the discussion? So especially as politicians rather than specialists become involved in the debate. So how do we change who's leading the discussion, Tamim? How do we work around that, considering what you've mentioned, that a lot of international organizations, UN agencies don't have enough representation of the people who are actually experiencing those health inequities in its sharpest form? So how do you balance that out, and how do you ensure that level of inclusivity at the top in terms of leading that conversation?
So I think the politician versus expert duality is another fallacy. Experts are experts in one thing, and a pandemic is not a one thing. And that has unfortunately dragged us into making oversimplifying and descending into a ludicrous conversation about science, no science, Fauci or no Fauci, and that isn't the right conversation to have. It is a complicated issue that touches every aspect of our lives, and it's not possible to have a singular expertise on it all. Not on a group of people, not on everybody, not on a single person. It's a complicated issue. So, and this has been starting to be talked about. The problem now is that it has become so polarized that if someone says, this is not just biomedicine, it's a multiplicity of things, the risk is that you end up playing into the hand of the anti-science, far-right anti-vaxxers, the whole salad of the cocktail of horribleness that happens elsewhere on the other side. But the point is, this duality is meaningless, and this duality is not only meaningless, it's harmful, because it deviates from the argument that let's go back to basic providing healthcare. Healthcare is predicated, at least in its ethical, supposedly form now, on informed consent and a decision made by the person affected. And it boggles the mind that as global health, we can't apply the exact same principle. So that could apply to children, as Louisa was saying. We perceive children to not be agents. They aren't not agents. They are fully agent in many cases. And we don't measure IQ and maturity of people. We've just had an arbitrary line of certain age that we decided people deserve to be, autonomous or not. Ask children what they want. most of the children I know are more mature than many of the adults I know, but that's beside the point. The other thing is, if we are going to talk about the life and death of people in its communities that those people know better than we will ever do, then our knowledge is teachable and transferable. Theirs isn't. So if there's an expert, it is the people who are at risk, and their expertise in their variable context is what determines how things actually succeed or not. So how about we ask people, what is it? Here's the information, here are the resources. What is it that we can do to help you? And then do what they tell us to do. The assumptions that people will be, will not know what to do, will not, have the wisdom, or will waste it, or will do it badly, or so on, is condescending, neo-colonialist, because we don't think that about, communities like Rust Belt in the US who do not want to vaccinate and think, the virus is a conspiracy by a lizard man cabal of, child eating, so on, are just misguided. But community in Africa or in the Middle East that have questions are just, progressive and don't really understand, uncivilized and so on. So let's ask people. There's an agency. People know better than us what's good for them. Our job is to provide them with as much objective information as we know how, and tell them what of it is proven to what extent, and let them decide. And that would be an exercise in agency rather than, paternalism.
Excellent, Tamim. Thank you so much. And Priya, the final questions for you. And it kind of draws on what you've already mentioned. What can the UK do differently in order to contribute to decolonizing global health? And I think you've mentioned how a focus on minority groups, being a lot more community-led. How can that start at home and then go globally?
Yeah, decolonizing health is really, really important. I mean, you have these programs for expert patients who have high blood pressure or suffer from diabetes, and some of the feedback from some of those, that learning that's made available to enable patients to become expert patients is that your traditional cuisine, your traditional way of life is just wrong, and that's why you have diabetes. That's why you have high blood pressure. So it starts from, and then especially sort of British, within my own network, family network, social network, and even professional network, I have members of, second, third, fourth members of these communities coming to me saying, it's our fault. And it's not our fault. So we need to, where do you start, Shireen? And there's so much that needs to be done. There's representation within these studies that we talked about it before. We need to spend more time with these communities. It's not just short, sharp, underfunded research projects to understand what a 2 or 3 key issues are. It's not just about understanding why people are not just engaging with the vaccine efforts or the vaccine program, but more generally, more widely, why they're not engaging with society, why they're not engaging with the health system in the wider sense. Understanding where all that comes from and why, mistrust and all of those things. So the decolonization project is going to take a long time because it is so embedded into every single aspect of the health system that it will take a long time for it to be addressed fully. But we have to start now.
Thank you so much, Priya, Tamim, and Louisa. Just as for closing, because we've reached the end of a very interesting conversation that I'm hoping to take forward in the upcoming months. A number of key points have emerged throughout the webinar today, that politics and economics are both central to a discussion on global health equity, and we need to work and think and address the various political economy dimensions of global health equity. That there may have been shifts at localization, within the localization debate, both locally within the UK in terms of more community-led work, but also more generally in low and middle income countries and conflict-affected contexts. But whether or not that localization shift is going to continue being more meaningful is a question to be asked. That social inequalities continue exacerbating pandemics, but also health problems more generally, and that there is a need for a much more nuanced approach that recognizes that complexity. We've also talked about the need for integrating multidisciplinary approaches and that the biomedical approach is not enough on its own. Quant data is not enough. You need to make sense of that data, complement it, triangulate it, engage with it, and really think about how, at a much more local level, how people are experiencing and coping with health crises. And then finally, that the conversation needs to change. That shouldn't just be focused on the outcomes, but the speakers, the leaders of that conversation, the conversation itself needs to shift. And we need to depart from the usual model of global north, global south bifurcation. That dichotomous view is not helpful. And it also feeds into the usual post-colonial approach to health inequities that we want to depart from, and that is no longer helpful. So I will leave you with this quick summary. A lot more interesting ideas emerged in this webinar, and I'm hoping that a recording of it will also be available to people who have not been able to join us today. I would like to thank the Global Health Centre for collaborating with us at NatSen International for organising this timely and relevant discussion. As I said, we are very keen on taking this conversation forward, and through NatSen's international work on global health equity, we are reaching out and collaborating with various departments and actors in the sphere. I'm very keen to hear from you if you want to be part of this broader conversation that we are taking forward. If you're interested in the work of the Global Health Centre and NatSen, please visit the websites listed on the screen and check our upcoming events and subscribe to our mailing lists. I look forward to hearing and engaging with all of you, and thank you so much for staying with us today, even though we went over time a little bit, and I look forward to taking this area of research forward with all of you. A big thank you to all of you, and have a lovely evening. Take care. Bye-bye.
Thank you. Thank you very much.
Thank you. Thanks to all panelists. Thank you.
Thanks.
Thank you.